This is part 6 on procedures of the abdomen. So the criterion for assessing quality of an abdominal radiograph, as far as the technique and exposure factors used, is the ability to be able to visualize the outlines of the psoas muscles, the lower border of the liver, the kidneys, and the ribs, as well as the transverse processes of the lumbar vertebra. So taking a look at the image that we see, these two images here, we're looking at the kidneys shown over here on the left and the right sides. We've got the psoas muscles, which are shown here. We want to be able to visualize those. We want to be able to visualize the transverse processes, very important. We want to be able to see the ribs, and then finally something that's not as shown as well on the image on the right, but we'll see it over here. Here's the liver. So we want to be able to visualize all those different parts. Immobilization, we want to be able to prevent both voluntary and involuntary motion. So muscle contraction can be a voluntary motion. It can be caused by tension. So if you just place your patient in a comfortable position, such as on a table pad, put a sponge under their knees, that can really help them to relax. If you explain the breathing procedure to them, that helps also so that they know exactly what is expected. So you want to make sure that you perform that on expiration, of course, on all of your abdominal images. You do not want to start the exposure for 1 to 2 seconds after the suspension of respiration occurs, and that way the patient can come to rest and involuntary movement of the viscera can subside. And it's very important to do so. The image that's shown here shows the bowel pattern, which is blurry in the right upper quadrant, and that's just showing that the patient did breathe during the exposure. So we want to make sure we give our patient a gown and we give instructions that they undress from the waist up, and we remove their pants and remove artifacts, but always give a gown. We use right or left side markers, and we always designate the upright if we upright or the side up if we're doing a decubitus exam. Now, explaining positions, supine positions, we're going to center the level of the iliac crest and the upright and the decubitus images, because we're going to want to be looking for air fluid levels with these two. We're going to center at the same location, which is 2 inches above the level of the iliac crest. And in all of the positions that we talk about of the abdominal procedures, we're going to suspend at the end of expiration. So we want to have a clean room. We want to have 40-inch SIDs recommended. We want to use a grid for all images, and we do not want to shield. On the AP supine, this will not show air fluid levels. So we're going to use this for perhaps bowel obstruction, neoplasms, calcifications, or ascites. The patient is going to be supine without rotation, and the mid-sagittal plane of the body should be to the midline of the grid device. We want to make sure the arms are out of the way so they don't cast shadows on the image, and support a sponge, put a support under the knees to relieve strain. It helps to relieve that voluntary motion that we talked about earlier. We want to make sure we set our collimated field at the level of the iliac crest and make sure that the pubic symphysis is included, which we can palpate the greater trochanters to ensure that. We went to center at the level of the iliac crest. However, we know many times we may need 2 images. So we want to adjust to 14 by 17. With smaller patients, you can collimate in terms of within one shadow of the abdominal planks on the image. So you want to see the size and the shape of the liver, the spleen, and the kidneys. We can visualize intra-abdominal calcifications or evidence of tumor masses. So looking at our image, we can see the psoas muscles, we can see the outline of the kidneys, we can see the transverse processes well visualized on the image, as well as the liver that's seen as well, and then even the ribs are shown too. The pubic symphysis is included on this image. This department did not require that the diaphragm was included. Many places are required as well. It just depends upon protocol. But 2 images may be required if the patient is too tall or too wide. You want no rotation, and exposure factors should include, as we've talked about before, the lateral abdominal wall, the the fat layer of the kidneys. We want to see the psoas muscles, the lower border of the liver, and the kidneys, the inferior ribs, and the transverse processes. So the kidneys, where are the kidneys? Well, when we look at the this image of the abdomen, we're finding that we do not see the actual kidneys themselves. We see an outline of the kidneys. So many times we call this what is referred to as a KUB, kidneys, ureters, and bladder, and we don't see only but just the outline of the kidneys on the image. We do not see the ureters at all, and we do not see the bladder at all. So just to point that out. The upright abdomen image, we're going to look at this for air fluid levels. This is the first choice for looking at air fluid levels. The patient's going to be standing upright. We're going to have the mid-sagittal plane of the body centered to the midline of the grid device. They're going to distribute the weight of the body equally on both feet. Put the arms so that they're not going to cast a shadow on the image, and we're going to center 2 inches above the level of the iliac crest, or high enough to include the diaphragm. We're going to adjust our image to 14 by 17, and just like we talked about on the previous image of the AP supine, we're going to collimate it within 1 inch of the shadow of the abdominal flanks for a smaller patient. Now we're going to be looking at the size and shape of the liver, the spleen, the kidneys, intra-abdominal calcifications, evidence of tumor masses, but the big thing is that we're looking for air fluid levels. So we want this patient in this upright position for how long? 5 minutes before the exposure. The top of the image receptor should include a xiphoid process, which is the level of the diaphragm. So we have another option, which is the PA upright. This is when the kidneys are not of primary interest, and we might want to decrease or greatly decrease gonadal dose. That would be a great thing. So we went to the anterior surface in contact with the image receptor instead, and we're going to center the exact same location, same central ray, same collimation, the same structure shown. Either image that we have is going to be the same criteria as the supine, except that we are going to see air fluid levels. We're going to see these lines that are on our image that are going to show that this is an upright abdomen image. Here's an image on the left-hand side versus an image on the right-hand side of a child. And we can see that if we're looking at the lines that are on this image, such as these lines going across here, that the image A is the upright image, B is the supine image. So another option we have if a patient is unable to sit upright or stand upright is to do a left lateral decubitus, which is an AP or PA projection. This case we're showing an AP projection. This is for air fluid levels in a patient who's too ill to stand. So it's going to show air fluid levels, as I said a couple times. We're doing a left lateral recumbent. We're going to make sure the patient's lying on their left side. The right side is up. We prefer this because we want the free air to settle around the liver and not the stomach. And the patient should be in this position for 5 minutes to allow the exposure, before the exposure, to allow the air fluid levels to settle. So we're going to have the patient on a radiolucent sponge, and we're going to flex the arms and the knees and the arms so that they're placed out of the way, especially the arms. And we're going to make sure we have the adjusted the height so that the IR is centered to the mid-sagittal plane. If the abdomen is too wide to include both flanks in one image, we want to adjust the patient the IR height to include the side down when intraperitoneal fluid is suspected, and to include the side up when a pneumoperitoneum is suspected. So a intraperitoneal fluid is fluid, pneumoperitoneum is air. We want to center at the level of the iliac crest, but usually we center 2 inches above the level of the iliac crest because we want to make sure we get the diaphragm on. So smaller patients, you're going to do the same collimation, and we're going to look at the size and shape of the liver, the spleen, and the kidneys, and very valuable for showing air fluid levels when an upright abdomen cannot be obtained. And so here's an image showing free air in this patient. This is something that we're going to see over the liver. This is something that's not normal. That's a pneumoperitoneum. And so the purpose is to show air and or fluid. The last possible image that we could do is a patient is unable to even lie on their side. And so this would be a lateral projection, a dorsal decubitus position of the abdomen. This time you're going to put the arms behind the head, and you're going to make sure with the vertical device is along the side and it's centered to the mid-coronal plane. We're still going to be centering 2 inches above the level of the iliac crest to ensure that we get the diaphragm on the image. We went to director beam horizontal because it is a decubitus, and we want to have the same collimation as we did previously. So we got the prevertebral space. It is useful in showing the air fluid levels in the abdomen, but like I said before, this is a third option that we have. How long are you going to have the patient lie before you take this exam? This image is going to be 5 minutes. So there's our image. We've got a lateral projection, which is a dorsal decubitus position of the abdomen. And we're going to be looking at, we don't want to have rotation. We want to see the open intervertebral foramina, which is going to be seen on the lateral projection, and as much of the abdomen as possible, and the diaphragm's included. So keep in mind, the supine position does not demonstrate air fluid levels. Air fluid levels, the number one choice is the AP upright or PA technically. The left lateral decubitus is number 2 if a patient cannot stand. And the dorsal decubit is like a number 3, taken if a patient cannot, oh, I just meant to pay lie, not die, yikes, cannot lie in a lateral decumbent position. So your positioning protocols are an AP supine abdomen. It's called a KUB. As we talked about, where are the kidneys? Well, we can't really see the kidneys themselves, but we can see the outlines. But it's also referred to as a scout or survey image. The other option we can do is an AP supine and upright. That's sometimes called a flatten and upright. It's an option 2. Sometimes we do an acute abdominal series of 3-way abdomen to roll out free air, a bowel obstruction, and infection. So that would be AP supine position, AP upright, and a PA chest. And you can always substitute the left lateral decubitus for the AP upright abdomen. And the purpose of, by the way, why we do the PA chest is that we can look at the air that accumulates under the diaphragm. Okay, thank you so much and have a great day.